Hello, this is the NICU Lived Network, and we are your hosts. I'm Melinda.
I'm Nat.
And I'm Emma. We are all NICU mothers using our lived experience to partner with health professionals to impact research, advocacy, and clinical practice.
Each week we will bring you something new. It could be a topic highlight, the latest in research, a visit to a NICU, or ways in which you can use your lived experience within the NICU to impact change. We hope you enjoy this episode.
Well, hello, we are back for another episode. Hi Nat, hi Em, it's great to see you both. And we are joined today by a super special guest, Professor William Tarnow-Mordi, who is the very first person who introduced me to the idea of being a parent representative and a parent voice to change health about 11 years ago now. And we're going to go back to that conversation. But before we do that, hi William, would love for you to introduce yourself.
Hi, well, thanks very much for having me on. My name is William Tarnow-Mordi, or my full name is William Odita Tarnow-Mordi. Odita is my Nigerian name, and it means let it be recorded in history, or whatever that's worth. And I'm the director of neonatal and perinatal trials at the NHMRC Clinical Trial Centre at the University of Sydney. I came to Sydney about 23 years ago from Dundee in Scotland, where I have been working for 14 years before that. And I've always been passionate about clinical trials. And I came as a director of neonatal intensive care at Westmead Hospital, but also as a professor of neonatal medicine at the University of Sydney. And since then, I've been doing trials, mostly multi-center trials. And I've been really inspired by the experience I had when I was training. And one of the things that really stuck with me is the experience of what's happened in kids with acute leukemia. When I was a medical student, kids with acute lymphoblastic leukemia, 90% of them would be dead in 1 year. And as a result of all the trials that have been going on in that specialty over the last 4 or 5 decades, the situation is now that more than 90% of kids with acute lymphoblastic leukemia will now survive for 5 years. And that's because they've been doing trial after trial in which 90% of the eligible kids have been in those trials because the parents and the clinicians have all been really committed to evidence. And that's what happens when you can really commit to doing trials in any one specialty. And my passion is to see if we can replicate that outside acute lymphoblastic leukemia, if we can see that happening in perinatal medicine so that kids in neonatal intensive care unit and mothers with high-risk pregnancies can benefit from the same sort of process.
So I mentioned in our intro that we had our first conversation about 11 years ago. Is that some of the stuff that inspired you, I guess, to make that call and take us back? Like, what do you recall of that conversation?
Well, I think the thing that came out that's stuck with me ever since our partnership started 10 years ago is your quote that we look forward to the day when one of the first questions that mothers and fathers of babies coming into NICU are going to ask is, are there any trials I can join, please? And I think that really puts it in the right perspective, that trials are a good thing. We hear a lot about the risks as opposed to the benefits, but in fact, the evidence is that particularly when you're looking at what we call phase 3 trials, you're actually better off being in a phase 3 trial than just having usual care. And the way it works is that by the time you've got to the process of, you go through phase 1, phase 2, phase 3 trials. Phase 3 trials are quite big. They're bigger than phase 2 trials. And by the time you get to phase 3 trial, you've already got a really quite promising hypothesis. And when you start to invite people to get involved in phase 3 trials, what a lot of people don't realize is that the actual benefits of being in the trial, whatever you get, whether it's the newer treatment or the older treatment, on balance, on average, you're likely to have a better outcome. And so for phase 3 trials, there's now quite a lot of empirical evidence that being in the trial, regardless of what you get, is going to give you a better outcome, both in terms of survival and in terms of the primary outcome of that trial. And I think that's the sort of thing that parents can help us to get across to other parents. And we need to put that kind of information in non-sensational language, but we need to get it across so that people can understand that by the time you get to phase 3 trials, the benefits actually, on average, outweigh any risks, and that we should be really, being open about the fact that trials are a positive thing, which are going to contribute to continued improvement in outcome for these for these vulnerable little kids and their families.
Yeah. And I remember in that conversation asking you the question, well, why do you need us? Like, why do you need parents' help in the design? Because up until that, my focus was, peer-to-peer support with families, offering resources, helping them through the journey. I'd never actually thought about a parent being able to be a parent voice in the design of trials or anything like that. And the two things that stuck out for me was one, that you had said that uptake into trials was quite low, which I think I said I understood, because it was a really big decision at the time for a parent to say yes to your baby being in a study, but also that it was becoming government policy, and that it was encouraged for consumers to be part of that. So, and I think for me, going through that, like, and understanding that, it's definitely been such a journey, and so much learning that's happened along the way. For me, it was definitely like a pivotal phone call to have that discussion, to say, you know what, parents can be empowered on this side and have a voice into helping change healthcare, which is amazing.
That's absolutely right. And I mean, basically, what's happened in those 12 years is that you have become an integral part of many of the trials that we've done. And that's one of the reasons why you were co-awarded the inaugural Consumer Involvement Award by the Australian Clinical Trials Alliance back in, I think it's 2018. So, yeah, a lot can be done. And the reason why we need parents is that without parents and without people with lived experience, we're really battling with one hand tied behind our back. And that once we get together and we put all our experience together, it becomes much, much more easy to persuade ethics committees that this trial needs to go ahead. I mean, would you like to tell us a little bit about what you did, Mel, at the ethics committee hearing for the Torpedo 3060 trial? What was your experience there?
We had Professor Julie Uy on talking about the Torpedo 3060 trial a couple of weeks ago. And that trial, because it's a comparative trial between two levels of oxygen that a baby would be given during delivery, we were looking for a waiver of consent. And the reason that was important, that was so that every single baby could be entered into the trial, so that we could get an answer sooner. And the two things, being asked to present to an ethics committee was quite nerve-wracking, but I think the two things that were really important was, one, that it was a comparative trial. It was two treatments that were already in practice, and it was really looking like, how can we relieve the burden of parents at that time? That was definitely a highlight, and I think a really important way for parents to have that voice and actually be able to change the trials. And I know that Nat's going to ask you about the types of trials that happens within the NICUs.
Sure.
I was just going to say, as a parent, like William, you've mentioned the phase 1, 2, and 3 trials, and Linda, you talk about the comparative trial. As a parent who doesn't really know too much about the types of trials, can you tell me kind of?
Well, I think the first thing to say is that the reason that we do trials is because we don't know all the answers yet. Mm-hmm. And that's a really important thing to understand. And a lot of parents get fazed by the idea that their doctor doesn't know everything. But that's the truth. And the reason that the outcome for babies has never been better than it is right now is because of all the trials and all the evidence that's been accumulating over the last few decades. So, there are different kinds of trials that go on. We talked about phase 1 trial. We don't do phase 1 trials in the neonatal intensive care unit, but phase 2 trials, where you've got an idea and you're trying it in maybe a few dozen or a few hundred families, a few hundred patients. They're the first step towards getting towards promising hypotheses, promising ideas. And the whole point about trials is that we're trying to test whether something is better than what we're doing at the moment. And unless we do that test, we will be stuck with the status quo. And that example I gave with the acute leukemia, it's like climbing a ladder. If you compare a different way of doing things with the current way of doing things, if there's no improvement, then you stay on the same rung of the ladder. But if there's an improvement, then you go up one rung and you got up a little bit further. And then you go from there. And so if you do trial after trial and you start building on those trials, then you can only go up the ladder. You can't go down. And that's what we need to be aiming for by the trials that we do in the neonatal intensive care unit. I think a lot of the emphasis needs to be on prevention as well. And so we need to look beyond the neonatal intensive care unit to try and see what can be done to prevent these babies being born at risk. And one of the great examples of that is the example of antenatal steroids. And in fact, that's the story that's captured in the Cochrane Library logo. And I remember when I was I was a registrar in Scotland when that Cochrane Library logo came to the fore. And it was basically putting together all the trials that had ever been done in giving women who were expecting a preterm baby antenatal steroids or not. And what it showed was that by giving them antenatal steroids just 48 hours or less before the baby was expected to be delivered, it reduced the risk of the baby dying by about 30%. And that's really an important step forward. And one of the trials that we're now looking towards taking forward throughout the world is using sildenafil, that's Viagra, as a prevention in any woman attempting vaginal birth. And the idea behind that is that there is a possibility that it may prevent fetal distress or reduce fetal distress leading to emergency operative birth. And so that's a very exciting trial, but it's got a long way to go. And I know that we're going to be in a much better position to make that trial happen if we're doing it in partnership with women and their families.
And I'm wondering, as a parent, if someone came up to me today, would like to be a child involved in a trial, so what questions should I ask? I've got no idea.
Well, I think you want to ask why the trial is being done, what the trial question is, and why they've come to the point where they think that's an important question. Yeah. And I think the more what we call health literacy, trials literacy, the more people can understand the basis of trials, then the easier it will be for them to understand why trials are important and why the different questions have arisen. And there's a really important website called Informed Health Choices, which is all about teaching children about how to understand why we need to do trials, fair tests. And I really strongly recommend that website for people to understand the background to trials.
Excellent. And I guess, you talked through that you and Melinda had a conversation, 10, 11 years ago. What would you say are some of the positives you've seen in the last 10 years of, really involving parents or people with lived experience in that design of trials within the NICU environment?
I think one of the really positive things is that parents get very quickly why it's important to do trials, and they're much less attuned to the risk side of the story than the benefits. They understand immediately much more closely than perhaps even the professionals, the frontline professionals do. So I think one of the benefits is that it's become much more accepted and an embedded part of our culture in neonatal care that trials should be happening. And what Melinda did with the Torpedo 3060 trial is a very good example. It's not really a negative, but what I've understood quite recently is that the other people that we need to carry with us and to take on board are the frontline professionals. And often all of this is new to them as well. And unless we reach out and involve them in the partnership, I think we're going to have a lot of barriers to taking this forward and really embedding it into the culture of the new learning health system that we need to be building.
Okay, all right. And how far do you think that partnerships between the parents and people that have gone through the journey, how far do you think that partnership can go?
Well, I think the sky's the limit, really. I think if we go back to that example of acute lymphoblastic leukemia, where 90% of kids used to die, 90% of kids have been involved and enrolled in trials because of that culture that they've had, and now 90% of those children survive. That's a model. That's a challenge for us in other specialties. The sky's the limit. I think that's the way forward.
How do you think they got to that culture?
I think it's just the fact that leukemia is clearly an emergency. I mean, at that time, 90%, you have to do something about that. The other thing is that you need to be collaborating with people around the world to get answers. Leukemia is a very rare disease. And in order to get the numbers that you need to get reliable answers, you have to collaborate. So those two ingredients, I think, helped to set the scene for why that specialty has become a real star example of what can be achieved elsewhere.
And a big question for Friday, what's your vision for, I guess, the involvement and moving forward? I mean, where would you like to see all this going? Big question for Friday.
Well, look, yeah, I want to go back to the 13th of August 1988, when I was a registrar at the John Radcliffe Hospital. I walked into the library, picked up a copy of the Lancet, and there was a trial called the ISIS-2 trial. 17,187 people who'd been admitted to coronary care units with suspected heart attack. And that trial looked at two things, aspirin and a streptokinase, an intravenous clotbuster. And what it showed was that they both were highly effective, but aspirin, just giving them aspirin to chew, reduced mortality by about 23%. And that has now become the mainstay of treatment. All of us know somebody who survived a heart attack. What we don't know, what we don't realize, is that all of those people are benefiting from that mega trial that was done nearly 40 years ago, because they're all given aspirin to chew. And if we go through a wide range of things like breast cancer, hypertension, preeclampsia, even being admitted to hospital with COVID-19, the successful treatments for all of those treatments are based largely on mega trials that have been done in the past. And that's, I think, where we need to be aiming for. We need to be getting the benefits of these large mega trials. We need to be making them by embedding and collaborating across the world in perinatal care and neonatal care. We need to be getting those benefits into our space as well, so that we can continue to really improve the outcomes. And a lot of people don't realize that those big trials, tens of thousands, they can be done very, very simply and very cheaply. And in fact, they only represent about 1% or less than 1% of all the trial activity out there. And we need to change that. And if we can get to the point where we recognize that we need to be doing these large, simple trials, then I think we'll have really made a big difference. And one of the ways that we can get there is by having a global movement towards empowering parents to understand about trials, particularly large, simple trials, so that they can start to become co-equal partners in making them happen. And so one of the ideas we have is a global training course, an online training course, a bit like Surf Life Saving Australia, with a bronze, silver medal, gold medal. And people who get through that training course will be able to sign up to be on a global register, so that trialists can contact them, whatever time zone they're in, towards becoming co-equal partners in the next generation of large, simple trials.
Yeah. We need to have you back for another episode to talk about that. Yeah, that's amazing. And I mean, yeah, absolutely. I mean, William, you're such a mentor for me. Like, it's an honor to have worked with you, to continue to work with you and see the amazing stuff that we can achieve. And you've been such an advocate for families. So thank you so much. And you are such an integral part of so many trials that are happening right now in Australia for babies. And like I said, we've spoken to Julie about Torpedo 3060, and we will be speaking to some of the other researchers coming up with WHAM and WHEAT and iSearch that you were just talking about. So it's going to be absolutely amazing. So thank you so much for talking to us.
Thanks very much. Well, thanks very much for having me on.
Yeah, it's brilliant.
Thank you.
Thank you. That's a wrap on another episode of the NICU Live Network. Thanks for joining us today. To stay connected, please make sure you're following us on social media and have joined our Facebook group.
And if you found value in this episode, please share, like, or comment.
We'll see you on the next episode.